Welcome to AETCM, the emergency medicine channel. Today let us discuss about one of the common emergencies in pregnancy, that is eclampsia and its management in emergency room. Eclampsia is a part of hypertensive disorder in pregnancy. Patient can have hypertension with convulsions, and patient can have history of preeclampsia during pregnancy or past pregnancy. And patient should not have neurological diseases which can lead to seizures, that is eclampsia. Suppose the patient is already having seizure disorder, then it will not come under eclampsia. It is a simple seizure disorder. Otherwise, if the patient is having encephalitis also, patient can develop seizure disorder. Malaria also, patient can have seizure disorder. So that all these complications should not be there. Hypertension with convulsion, and convulsion is a part of the hypertensive disorder in the pregnancy, that is eclampsia. Preeclampsia is defined as new onset of hypertension, that is BP more than 140/90, proteinuria more than 300 mg 24 hours, and pathological edema during pregnancy. So all these things are very important. All these complications or all these features developing after 20 weeks of gestation and in a previously normotensive lady, that is preeclampsia. One of the component of eclampsia and preeclampsia syndrome is HELP syndrome, hemolysis, elevated liver enzymes, low platelets, all these things. So there is another syndrome, it is called as HELP syndrome, but it can be a part of eclampsia because some of these patients can go to eclampsia phase. Marked elevation of BP more than 160/100, severe proteinuria, some patients can have oliguria also, central nervous system dysfunctions like headache, blurred vision, coma, seizures. So high BP, proteinuria, seizures, that is eclampsia. High BP with proteinuria, that is preeclampsia. Some patients can have renal failure, that is elevated creatinine more than 1.1 mg per deciliter, or doubling of serum creatinine in patients without any other renal disease. And many patients can have pulmonary edema, liver injury, thrombocytopenia, and visual disturbances. Sometimes they can lead to disseminated intravascular coagulation. So these are the components of eclampsia, but in a patient who is having high BP and seizure itself, we can make a diagnosis of eclampsia. Other components like we discussed, patient can have CNS manifestation, renal failure, hepatocellular injury, pulmonary edema, thrombocytopenia, visual disturbance. So all these things are a part of high BP. So they can also be considered as part of eclampsia. Pathogenesis of preeclampsia is very important. It occurs due to the reduced perfusion of placenta, that is very important, which leads to widespread endothelial damage or dysfunction. The main cause is abnormal placentation, so defective invasion of the spiral arteries by cytotrophoblast cells and lead to endothelial dysfunction. So that is a mechanism of developing all the problems. This endothelial damage is the main problem which can lead to hypertension. There are a lot of risk factors which can lead to preeclampsia, or in a patient who is having these histories, patient can develop, there is a high chance of development of preeclampsia and eclampsia and HELP syndrome in this type of patients. Prior preeclampsia, multifetal pregnancy, prior stillbirth, nulliparity, prior placental abruption, older maternal age, chronic hypertension, chronic renal disease, pregestational diabetes, antiphospholipid antibody syndrome, systemic lupus erythematosus, and increased body mass index. All these things can be a risk factor for preeclampsia, and that most important is prior preeclampsia and multifetal pregnancy, age of the mother. All these things are very, very important. Now, preeclampsia and eclampsia account for approximately 63,000 maternal deaths annually worldwide. So it's a high mortality disease. As many as 56% patients with eclampsia may have transient deficits including cortical blindness. So blindness is a feature of preeclampsia, may be a part of Press syndrome. We don't know what exactly is the problem. So blindness can be there in many patients who is having preeclampsia or eclampsia. 56% of the patients can have this type of problems. Other complications like permanent neurological damage from recurrent seizures or intracranial bleed. Recurrent seizures can sometimes lead to severe hypoxemic brain damage. That's why permanent neurological damage are seen in this type of patients. Renal insufficiency and renal failure can occur in many patients. Fetal changes like intrauterine growth retardation, abruptio placenta, oligohydramnios, all these things can be a complication of eclampsia. Hepatic damage, hematological compromise and DIC, increased risk of recurrent eclampsia and preeclampsia in following pregnancies, and maternal and fetal death. If not treated properly, 13% of maternal deaths are due to preeclampsia worldwide. Now, intrapartum complications like fetal growth retardation, fetal heart rate disorders, placenta abruption, all these things are major complications of eclampsia and preeclampsia. Now, once we diagnose preeclampsia or hypertension in a patient who is having pregnancy, whether it is gestational hypertension or pre-gestational hypertension or preeclampsia, whatever it is, we have to control the blood pressure and we have to monitor the fetus properly, because some diseases associated with eclampsia like antiphospholipid antibody syndrome and all can have fetal heart damage, and it can fetus can have altered rhythm in the heartbeats. So fetal monitoring is very important. Complete bed rest can be advised, but one of the problem of complete bed rest is the patient can have DVT, deep vein thrombosis. So if a patient is able to walk, better to do some minimal exercise or minimal walking during pregnancy. Otherwise, some patients can develop deep vein thrombosis during pregnancy. So complete bed rest is can be advised, but we have to advise the patient to have minimal walking or minimal exercise during this bed rest. Otherwise, some of these patients can develop deep vein thrombosis. Diet, normal diet, reduce salt, that is better. Calcium supplements can be can have some benefits during hypertensive episodes, or hypertension can be slightly controlled with calcium intake. Low dose aspirin can reduce the risk of preeclampsia induced complication to the child. When we discuss about antihypertensive, almost all antihypertensives can be given during pregnancy except AC inhibitor and angiotensin receptor blockers. So they are contraindicated, and diuretic also should be used very carefully in a patient who is having eclampsia and preeclampsia, because that further reduces the placental blood flow if it produces dehydration. So diuretics should be used only if there is a complication like pulmonary edema. Otherwise, it is not a good drug in preeclampsia and eclampsia. All other drugs other than AC inhibitor, ARB and diuretics can be used in pregnancy. If the patient is already on some drugs before pregnancy, that itself can be continued. But if it is AC or ARB, can be changed to some other drug. Now, BP targets. The recommended target is antihypertensive treatment for a new onset systolic BP more than 160 or diastolic BP 110 millimeter of mercury, with a goal of BP less than 160, less than 110 millimeter of mercury. So that is a recommendation by Society of Obstetrician and Gynecologists of Canada. Then a patient with chronic non-severe hypertension, that is 140 to 159, 90 to 109 millimeter of mercury without comorbidities, hypertensive therapy can be used to can be started to keep the systolic BP at 130 to 155, diastolic BP 80 to 105. So we can slightly reduce the target from the first recommendation to 130 to 80. For women, chronic non-severe hypertension with comorbid conditions, antihypertensive drug therapy should be used to reduce the target to SBP less than 140, diastolic BP less than 90. So whatever it is, BP should be controlled properly during pregnancy. So we can keep a target like SBP at 130 to 155, diastolic BP 80 to 105. That is a better target among all these recommendations. Complicated hypertension. For pregnant women with complicated or secondary hypertension with target organ damage, left ventricular hypertrophy, microalbuminuria, retinopathy, dyslipidemia, or age of the pregnant lady more than 40 years, previous history of stroke, previous history of pregnancy loss, diabetes. In all these conditions, we should not hesitate to start the treatment. Immediately we have to initiate the treatment irrespective of the investigations. Now, in a patient who is having high BP during pregnancy, that can be called as eclampsia, because patient may develop seizure afterwards. So initially they may present only with high BP. Labetalol is the choice of drug there. So because labetalol is available widely and can be used without any problems. Only problem is if the patient is asthmatic, sometimes patient can develop asthma. All patients will not develop asthma because of labetalol. Those who having a problem with beta blockers induced asthma only develop breathlessness. Otherwise, many patients, even with asthma, they tolerate labetalol, but some patients can have acute bronchospasm. In that type of patients, will not be able to use this drug. Labetalol 2 mg per minute up to 300 mg or 20 mg over 2 minutes, then 40 to 80 mg at 10 minutes interval up to 300 mg total can be given. Other drug of choice is IV hydrolysine. At present it is not available in India. This IV preparation is not available. Oral tablets are available. We can even try that, but it takes little more time to act comparing to IV. 10 to 50 mg at 30 minutes interval in severe hypertension. So IV hydrolysine is a better choice, but at present in India IV hydrolysine is not available, so we can go for oral tablets. Calcium channel blockers like nifedipine immediate release tablet should be given. We should know that nifedipine has got immediate release and sustained release tablets. Sustained release tablets will not be released immediately, so we have to use normal nifedipine tablet. It should not be given as sublingual also. We can give oral tablet. Nitroglycerin is another easily available drug everywhere. It can be started IV 5 microgram per minute, gradually increased to 3 to 5 minutes, maximum of 100 microgram. Sometimes if BP is not getting control, you can even raise up to 200 microgram per minute if preeclampsia is associated with pulmonary edema. So in pulmonary edema, this is a very good drug because it can produce both venodilatation and arterial dilatation. Now, some of the drugs we should avoid in eclampsia and preeclampsia. In that, most important drugs are ACE inhibitors, ARBs, and direct renin inhibitors. They are all contraindicated in pregnancy. Diuretics can be used. There is no actual contraindication, but if there is a volume loss and if you give diuretic, again intravascular volume can reduce, and that further increases the BP because placental circulation will drop because of the intravascular volume loss. So diuretics should not be used unless until there is pulmonary edema or breathlessness or fluid overload in a patient who is having eclampsia or preeclampsia. Now, prevention of seizure is very important in preeclampsia. So, patients who is having preeclampsia during pregnancy Give intrapartum and postpartum seizure prophylaxis with magnesium sulfate. Dose 6 gram IV and then 2 gram per hour infusion. So in an eclampsia patient, if the BP is high, even if there is no seizure, we can start magnesium to prevent seizures, because this is the treatment of seizure during eclampsia. So if you start early, it can be prevented. So this is the treatment for severe preeclampsia. Most important things are, we can reduce the BP with labetalol or hydralazine, or NTG can be used. We can use magnesium sulfate to prevent seizures. Then corticosteroids can be given for lung maturation. Other vital signs should be monitored properly, and we have to rule out HELLP syndrome. Some lab investigations are required. Definitive treatment of eclampsia and preeclampsia is always delivery. Delivery controls the problem in eclampsia and preeclampsia. Now, if the patient develops seizure, or if the patient is admitted with seizure, we have to take care of patient's airway, breathing, circulation. There is a chance of aspiration. We have to keep the patient on left lateral position if possible. Then oxygen should be given if there is hypoxemia. Blood sugar should be corrected, because patient with seizure can have hypoglycemia induced seizure, or seizure itself can produce hypoglycemia. So oxygenation, blood sugars, all these things should be controlled. Magnesium sulfate is the treatment of choice in seizures. 6 gram bolus over 15 minutes IV, 1 to 3 gram per hour continuous infusion for next 24 hours postpartum. But when we are giving such high dose of magnesium, there is always a chance of hypermagnesemia, especially when there is renal failure. So we have to be very careful when we are giving magnesium sulfate. We can check the deep tendon reflexes, knee jerk, always. Suppose if the knee jerk is disappearing, we should know that patient is going for magnesium toxicity or hypermagnesemia. We have to immediately stop the infusion. Otherwise, we have to check magnesium levels in frequent intervals, so that patient will not go to hypermagnesemia. Every 6 hours we have to do the magnesium levels. If magnesium levels are increasing, we can stop the infusion of magnesium, infusion. Calcium gluconate is an antidote for hypermagnesemia and magnesium induced cardiac toxicity. So we can give 10%, 10 ml over 10 minutes, same protocol for hyperkalemia also. Here also we can give the same protocol. That's an antidote for magnesium induced cardiac toxicity. There are some alternatives like those patients who is having myasthenia gravis. Myasthenia gravis, we cannot give magnesium sulfate because it can aggravate the problem in the myasthenia gravis. So we can go for alternative drugs like levetiracetam. One of the most preferred drug in pregnancy. Many other conditions also it is preferred drug, because it has got lesser side effect when we compare with phenytoin and valproic acid. So levetiracetam can be given as a loading dose of 1 gram, then 500 milligram TID can be given as infusion. Phenytoin is also an alternative. Valproic acid is also an alternative. And we can even give lorazepam or midazolam during acute seizures to control the seizure, because whether it is magnesium sulfate or valproate or phenytoin, all these things take some time to prepare the infusion and act. So immediately what we can give is diazepam or lorazepam IV can be given. Even midazolam nasal spray also is available, can also be tried, but the action is not that like a IV diazepam. So we have discussed about one of the most important problems in pregnancy, that is preeclampsia and eclampsia. In emergency room, our aim is only to maintain the patient's airway, breathing and circulation, control the BP with labetalol infusion. If the patient develops seizure, we have to treat with magnesium sulfate. During magnesium sulfate infusion, patient can develop toxicities, cardiac toxicities are common. So we should be ready to handle that also. So we can give calcium gluconate if the patient develops magnesium induced cardiotoxicity. Periodic checking of magnesium levels are very important. Knee jerk also can be tested periodically. All these things can be done, but ultimately the treatment of choice in preeclampsia, eclampsia, HELP syndrome, all these things is delivery. So once the patient is delivered, then the problems will settle very fast. Thank you.